welcome you to today's webinar, Evaluation and Treatment of Adolescents with Co-occurring SUD and General Psychiatric Disorders. We're so thankful that you're here. And as a reminder, my name is Ellen Robertson, and I am the APCP Project Director. This presentation is hosted by VITAL, Alabama Medicaid, Alabama Department of Mental Health, APCP, and Project Freedom. So very, very briefly, again, the APCP Project and VITAL are two of the sponsors of this webinar. And we look at opioid use disorder and education and training around a lot of different topics around substance use disorder as a whole. VITAL also looks at mental health, mental illness, and they focus on evaluation, training, and advocacy. Today, the speaker and planners have no financial relationships to disclose. And without further ado, because I'm speedy through this because I've seen the slides and he has a lot of great information. So I want to give him all the time that he can have. So it's my pleasure to introduce you to today's speaker, Dr. Stephen Taylor. Dr. Taylor is board certified in general psychiatry, child and adolescent psychiatry, addiction psychiatry, and addiction medicine. Dr. Taylor is completing his 14th season as the medical director of the Player Assistance and Anti-Drug Program of the National Basketball Association and the National Basketball Players Association. Dr. Taylor also serves as the Chief Medical Officer of the Behavioral Health Division of Pathway Healthcare, a company that has opened and is operating 13 outpatient mental health and addiction treatment offices across Alabama, Mississippi, Tennessee, and Texas, and is currently working on opening offices in Louisiana and Virginia. He is an honors graduate of Harvard College with a Master of Public Health degree from the Harvard School of Public Health and a medical degree from Howard University College of Medicine. So please type any questions that you have during the presentation in the Q&A or the chat, and Dr. Taylor will answer those at the end of the presentation. So Dr. Taylor, take it away.
Thank you so much, Dr. Robertson. Good afternoon to everyone. Thank you for joining us for this webinar for a topic that is near and dear to my heart, a topic that I've been teaching about and working in this area for more than 25 years. And I'm very excited to be able to share some information with you on this topic of evaluation and treatment of adolescents with co-occurring substance use and general psychiatric disorders. I'm going to advance the slides here. I know I have control of the screen, provided I know what I'm doing. There we are. Here's our agenda that I wanted to cover today. And as Dr. Robertson alluded to, it's a full agenda, a lot of stuff I want to cover, a little bit of an introduction, some definitions, epidemiology of some of these disorders, risk factors for adolescents, and then sort of a general approach to the adolescent patient with substance use and co-occurring general psychiatric disorders, some warning signs for adolescent substance use, how does drug use start in young people, and then of course I've got a slide that I want to share with you on some of the screening tools for adolescent substance use and for adult addiction disorders for that matter. And then we'll talk a little bit about treatment. And the National Institute on Drug Abuse has actually published some principles that I want to cover with you. And then we talk a little bit about the behavioral health treatment modalities, and then pharmacotherapy. Believe it or not, there are people who provide pharmacotherapy for adolescents with substance use disorder, not just for general mental health disorder. And that's something that should be addressed because it's far too underutilized, hence the question mark on this agenda slide. So a lot that I want to go through, and let's jump into it, starting with addictions. I am a member of the American Society of Addiction Medicine. In fact, I'm on the board of directors of that organization. And ASAM puts out definitions to really help people understand and make sure that we're all on the same page and talking about the same thing when we use terminology like addiction disorders or substance use disorder. And specifically, this short definition of addiction is useful to understand if we're talking about treating adolescents with addiction or substance use disorder, which is two terminologies that can be used interchangeably. So addiction is a treatable chronic medical disease. And I'll stop right there at that first line, because there alone, we're saying something that many people in this society to this day do not understand fully, or at least do not apply that understanding to the way they approach people with substance use disorders or addiction disorders. That addiction is treatable. I literally was just giving an interview this morning with a CNN reporter and had to point out that there was a recent study done in Massachusetts that a survey of healthcare professionals, and come to find out a shocking number of current healthcare professionals did not really believe that addiction and particularly opioid use disorder was even treatable. But in fact, it is treatable to the point where that should be first and foremost in the definition, and it is, as you see it here. So addiction is treatable. Also, that it is a chronic medical disease. And that is to say that if you take someone and you put them in treatment one time and they come back out of treatment and they have a recurrence of illness, commonly referred to as a relapse, that doesn't mean that that's an unsuccessful episode of treatment. It doesn't mean that there's something wrong with that individual. It means that the disease that they have is a chronic disease, which by definition can have remissions and exacerbations and relapses, and those need to be dealt with the way we would deal with the remissions and exacerbations in any chronic disease. So it's a treatable chronic medical disease. It involves complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. And again, that needs to be emphasized, because that explodes another myth about addiction disorders, which suggests that their addiction is much harder to treat. If it's treatable, it's much harder to treat. And the success that's seen in treating folks with addiction disorders is so much less than the success that you see in treating people with other disorders. And that simply is not borne out by the body of evidence, a very large body of evidence by this point in time. So that is ASAM's short definition of addiction. And this is a user-friendly definition of addiction that I have actually developed and have utilized, and I would share it with you and encourage you to, if you're gonna commit anything to memory, commit this to memory, this user-friendly definition of addiction, specifically the 3 planks that you see here. So remember that addiction is a primary chronic relapsing disease, a brain disease, characterized by, number 1, loss of control of one's use of a drug. Number 2, continued use of that drug despite adverse consequences of that drug use. And then number 3, an obsessive desire and or compulsive seeking for the drug. If you remember those 3 features, then you have a very good working definition of addiction. It helps you to communicate that to patients. I personally have worked with adolescents as young as 13 years of age and have had them consider these 3 planks of this definition: that loss of control over use, continued use despite adverse consequences, obsessive desire, compulsive seeking. And I've been able to get 13-year-olds to apply those 3 planks to their own use of alcohol or their own use of marijuana, and realize for themselves that they are already developing the beginnings of an addiction disorder. And once you can get an adolescent to do that for themselves, then you can really get a foothold into trying to help them. And so it's that user-friendly a definition that I've been able to get 13-year-olds to apply that and to begin to get some insight so that I'm able to then work with them. Obviously, the reason why we're talking about this topic today, specifically regarding adolescence, is because this disease of addiction usually starts in adolescence. And that's why I trained in child and adolescent psychiatry as well as addiction psychiatry, rather than just doing adult psychiatry. I felt it was important to try to work with that young population of folks in whom this disease gets its start. And then, of course, that last part of the definition, also you see that right at the beginning of ASAM's definition. It is treatable and controllable, but the part that's not necessarily said in the ASAM definition, but I spell it out here, is not usually curable. And so for people to understand that, for families that you work with to understand that, is key. That this is about controlling a chronic condition that can have relapses and can go back and forth between periods of relative remission and then periods when there are exacerbations. But you're controlling a chronic illness. You are not cured after you've gone through treatment. That is, believe it or not, one of the most important principles that you can make sure that families and the young people that you work with understand. The next slide, whoops, I went too far over one. Let me see if I can go back. If I don't, nope, I'm just going further forward. Let me see if I can go back a little. Here we are. So why adolescence? And I touched on this a little bit on the previous slide. Why adolescence? Again, this is a disease that gets its start in adolescence. Substance use counts for the vast majority of life years lost due to disease, disability, and premature death in this adolescent and young adult age group from ages 15 to 24. Substance use is arguably the most important modifiable health risk behavior impacting adolescents, and integrating substance use treatment within the pediatric primary care of young people, and engaging primary care physicians and primary care providers to manage substance use disorders like other disorders, like other chronic medical diseases, well, that could increase substance use disorder treatment among youth. And also the undertreatment that we see, that is a rampant problem in our society, the undertreatment of substance use disorder and opioid use disorder in particular, is due to the fact that there's a dearth of providers who are trained and capable of treating people, particularly young people, with substance use disorder in general and opioid use disorder in particular. So I want to talk a little bit about epidemiology. I said that that's the next step on our agenda. And I wanted to tell you about a study. Really, it's not a brand new study, but it's still one of the better studies that you will find in the literature on co-occurring general psychiatric illness and substance use disorder, specifically in adolescents. This was a study that was actually published by Roberts and et al. From the University of Texas Health Science Center at Houston. And it was published in the journal Drug and Alcohol Dependence in the year 2007. And this study looked at the comorbidity of different types of substance use disorder. And it examined the comorbidity separately for what used to be called substance abuse, and used to be a diagnostic category in the DSM for substance abuse, versus substance dependence. We don't really separate them out that way anymore. In the DSM-5, we really have a list of different criteria and a graded understanding of the severity. And in the less severe range, it corresponds roughly to what used to be called substance abuse. And in the more severe range, it corresponds to what we now understand, what we used to understand as substance dependence. But this was a study from back at the time when there were these separate diagnostic categories for substance abuse and substance dependence. This study looked at over 4,000 pre-adolescents and adolescents aged 11 to 17. And what they found was that dependence, but not abuse. In other words, at the more severe end of the diagnostic spectrum of substance use disorders, that increased risks for anxiety disorders. And both of those categories, abuse and dependence, increased risk of mood disorders, and that there was greater comorbidity with psychiatric disorders with dependence versus abuse. And if you think about it for a minute, that makes some sense, that as you're along the more severe end of the scale of this diagnostic entity, that there's going to be greater comorbidity, greater co-occurrence with general psychiatric illness, and that it will increase the risk for anxiety disorders in particular. That study also found that marijuana was less associated with comorbid psychiatric disorders than alcohol or other substances. It found that the strongest association was for comorbid disruptive disorders, regardless of the substance use disorder category. So whether it was at the less severe end of what used to be considered abuse, or the more severe end in the dependence category, the strongest association was for disruptive disorders, things like attention deficit hyperactivity disorder and conduct disorder. Also for substance use disorders and general psychiatric disorders, those young people for whom there was co-occurrence of substance use disorder and general psychiatric disorder, no real surprise that they found that there was substantial functional improvement among that group of young people. They also found, interestingly, that females with substance use disorder tended to have higher rates of comorbid general psychiatric disorders. And it's, you know, I found that such an interesting finding, in part because that very much coincides with the experience I've had over the years treating adolescents with substance use disorder. In general, with adolescents, we look at comorbidity, co-occurrence of general psychiatric disorders, and expect to see it even more than we do with older adults. But particularly the fact that the females with substance use disorder tend to have higher rates. That's something that I saw in practice and really wondered if that was a real finding, if it would hold up when studied formally. And sure enough, in this study of over 4,000 young people, that did seem to be a finding. There was no difference, however, observed between different ethnic groups. And that too, to be honest with you, tracked with the experience that I've had clinically and with other data that has been published, that there really doesn't tend to be that big a difference observed between different ethnic groups. This is a slide from the National Comorbidity Survey Replication Adolescent Supplement. The National Comorbidity Survey is a survey of over 10,000 adolescents that was done in the year 2001 to 2004, as you see here. And it really just looks at the general conditions and comorbidity for adolescents with prevalence of any mental disorder. And what we're seeing here is that when you look overall, almost half, 49.5% of adolescents in general, as a group, have lifetime prevalence of any kind of mental health disorder. Almost half, or just about half. So that is a significant prevalence. That means that to not pay attention to adolescent general mental health conditions is to literally ignore a huge problem with high prevalence. What we also notice, though, is that there's the breakdown between female and male is slightly more female, slightly less than half the male, but a very fairly even breakdown. We notice also that as people get from younger age groups to the older age groups, the prevalence increases. But even at the younger age groups, age 13 to 14, for 45% of 13 to 14-year-olds to have lifetime prevalence of mental disorders is a significant prevalence. And then that even goes up from there to 49% at age 15 to 16. You're up over 50%, at over 55% actually in the 17 to 18-year-old age range. So that is the prevalence in according to that study. And then the next study that I wanted to share was a study that was actually published just last year, but very, very interesting information looking at children's mental health emergency department visits over a 9-year period between 2007 to 2016. And then, of course, in the course of the pandemic that we are currently experiencing, we all know that the mental health of the entire society, but particularly of children and adolescents, has really taken a hit, and we've had much more of a problem with depression and anxiety and various other mental health conditions. But even in those 9 years from 2007 to 2016, which is what this study looks at, what they found was there's a significant increase in mental health emergency department visits. This is a study that was published by Charmaine Lowe and her colleagues at the Division of Emergency Medicine at Nationwide Children's Hospital in Columbus, Ohio. And again, it was published in the journal Pediatrics just last year in 2020. And this is the finding that they report. Increasing numbers of children with mental health disorders turning up in emergency rooms. And what you see here depicted in this table here is, and this graph, excuse me, is the percent change since 2007. And if you notice, here's any mental health disorder with the triangle, and there's a significant increase here. But what really skyrockets is deliberate self-harm diagnosis. Look at the way that has skyrocketed from 2007 to 2016. 300% change from 2007 to 2016. So many young people presenting to emergency departments after engaging in some deliberate self-harm behavior. And then, of course, we also noticed, particularly going from 2014 to 2016, the increase, a fairly significant increase in substance use disorder diagnoses in this period of time. So, and again, all-cause pediatric ED visits did not go up nearly that much. So we really are looking at these increases due specifically to mental health disorders, and the greatest driver of those, deliberate self-harm diagnoses. So that is very, very significant and very concerning. So I like to talk about adolescence and think about adolescence. Again, it's this period of time when we know that there's the increased risk for development of substance use disorder in particular. That's when it starts. But also we see that in adolescence, there's a tremendous prevalence of general mental health conditions, as I've just demonstrated to you. And the question is, well, why? What's so unique about adolescence? What's so important about adolescence? And of course, this slide just tries to get at some of that. Obviously, there are developmental considerations that are normal development. And that's the thing that's so striking. The normal development that we would expect and would want, in fact, for every adolescent to go through is actually fraught with challenges. And you can find in this normal development some of the reasons why adolescence is the time when substance use disorder and general mental health disorders can often take root. This is a period of time of separation and individuation from parents, questioning authority, developing abstract versus concrete thinking. The importance of peer influence and acceptance increases. That this is the point for all of you who've ever raised an adolescent, and most of us on this call probably have or are doing so now. What you come to understand is that right around the time your kid turns 13, you become stupid. You all of a sudden don't know anything about life, and it is the other 13-year-olds in your adolescence world who are the people who are most knowledgeable about life and whose opinions matter the most and whose judgments about the world are the really knowledgeable judgments. And you are stupid. You don't know anything about life all of a sudden at age 13. And generally speaking, you don't start to get smart again until your youngster gets to be 25 or approaching 30. Then all of a sudden you become smart again. And that's because of this importance of peer influence and acceptance at this age group. Also, exploration and experimentation is something that adolescents are normally supposed to do, but it's also something that puts them at incredible risk, particularly regarding substance use disorder. Hormonal development, every parent worries about that because you have these hormones that develop and this neurobiological maturation that's taking place while their judgment is not yet intact. That is a mix that can be very worrying for parents. And I mentioned judgment not being intact. Here is a depiction of research that came out quite some time ago now, a couple of decades ago, but demonstrated what we now all know, and it's all old knowledge now, that the adolescent brain, the brain development in young people proceeds from back to front, and it proceeds slowly. And it's back to front. It has to be from back to front because in the back, where the base of the brain is where the brain stem is. That's where all of the functions you don't have to think about, like keeping your heart beating and continuing to breathe, the things that don't require higher level cognition, those things can continue on in order to keep a person alive. But then that brain development goes from back to front. And the very last part of the brain to develop is all of the most sophisticated brain functions, all of the careful reasoning, the making choices, the making executive decisions, executive functioning, thinking through the possible consequences of one's actions, weighing out one's values and deciding which actions are consistent with one's values or with the values that one wants to aspire to and wants to embrace, and which actions are inconsistent with those. All of that higher level kind of thinking and judgment, delaying gratification in order to reach a goal that one has decided is a more important goal. All of that is done at the prefrontal cortex, and that involves the higher brain centers, and those unfortunately are the last parts of the brain to develop, and in many cases they're not even close to being fully developed until at least age 25. This slide takes you up to age 20, but really it's at least age 25 that we know before that develops. And by the way, in this developing brain where there's demyelination of neurons, the last thing you would think that would be helpful here is to introduce some poison like alcohol, for example, into this developing brain. And in fact, what we see is that young people who engage in drinking alcohol, for example, before age 15 are 4 times more likely to develop an alcohol use disorder than those who wait until after that age group. So here's some risk factors for adolescent addiction disorders. Family history, I quote this all the time. I think it's really important to remember. The #1 risk factor for a young person to develop a substance use disorder is to have a parent who has or has had a substance use disorder, okay? But also early initiation, as I just mentioned. Young people who initiate drinking before age 15, 4 times more likely to develop an alcohol use disorder than those who started after age 20. Early patterns of drinking tend to be more likely to reflect environmental influence. Later patterns of drinking are more likely to reflect genetic influence. That's also been found in studies that have been out there for a while now. And then the spectrum of externalizing disorders, the genetic risk for young people to develop alcohol and drug problems may be related to that entire spectrum of what are called externalizing disorders. Again, things like ADHD and conduct disorder. There's also, of course, we know that like many medical conditions, substance use disorder has a gene and environment interaction. There's partly genetics that contribute to this condition. It's partly environmental. That's even in ASAM's definition that I read to you earlier. And so here are some of the various factors that you have to think about. Childhood stressors, what we now refer to as ACEs. And I gave a whole talk on ACEs 2 weeks ago, the adverse childhood experiences, such as emotional, physical, or sexual abuse being just examples of them. There are 10 on that list. And again, I talked about that a couple of weeks ago. Childhood stressors, the availability and access of substances. The fact of the matter is, I've personally taken care of young people who started, the first drug they ever used was cocaine, because that was a drug they actually had easy access to. Peer group behavior, you tend to do what your friends do, and that's been shown. And then parental attitudes and monitoring, and I'm going to say a little bit more about that in a minute, but that is incredibly important. A lot of parents don't realize that their attitudes towards substances and their own behavior regarding substances have a tremendous amount of impact on their young people and what they do, and also how closely you monitor them. If young people feel like they're not being monitored, they're going to try things that they might not otherwise try if they know they're going to get caught, and the consequences of getting caught are not pleasant. And then also religiosity is a factor. There's a study that actually shows that, particularly this study that looked at females actually, that shows that alcohol use was either delayed or just completely deferred among females who tended to be more involved in religious activity, who considered themselves to be more adherent to their religious faith. It was actually a very interesting finding, and it's one that people generally accept as valid, not just for females, but for males as well. But this particular study cited here looked at females. So general approach to the patient. And obviously this is a good thing in general, but I think it's worth mentioning specifically when it comes to adolescents. And that is, one, you've got to develop a rapport with adolescents. That is the most important thing to do. Establish that patient's trust, make it clear and obvious to them that stigma and or judgment and or shame, that's just not going to be an issue. That's not going to be a part of your interaction with that young person. You're not there to judge them. You're not there to discipline them. They've got parents for that or other parental figures. You want to really engage in an interaction with them where you're partnering with them, where they know they can trust you, because you're trying to help them to get an outcome that's in their best interests. And of course, when it comes to that, actions speak louder than words. Okay, so we can say that I'm not going to judge you, but it's also in the way you talk with them, the way you arrange seating can be important, and just your general body language can be incredibly important. And I put this quote in from Maya Angelou because I think it's so important in what we do in working with young people. At the end of the day, people won't remember what you said or did. They will remember how you made them feel. And one of the things that I've learned, interestingly enough, is that if you've made a young person feel validated, if you've made them feel like they've been listened to, like they are treated with respect, even if you are open and totally honest with them, as you should be, that you don't necessarily agree with some of the things that they're doing, you don't think that those things help them and are in their best interest, but if you let them know that you're respecting them and you're not judging them and you're there to partner with them to try to help them move towards solutions that are in their best interest, people remember that you made them feel that way, and they'll come back and they'll spend more time with you, and they're at least willing to listen and consider what you have to say regarding what's going on with them. Obviously, these other parts of an evaluation are very important, and I don't need to do a basic lesson on doing an evaluation. I mentioned before that I wanted to come back to this issue of parental attitudes. I had occasion a few years back to be a member of a panel discussion at a high school. And a friend of mine was also a member of that panel. And we were on this panel discussion together. And a parent raised their hand and asked the question about, after the panel discussion was over, about privacy, the need to respect an adolescent's privacy, and even though, and how do you balance that with the fact that you're concerned that that adolescent may be using some substances or may be involved, getting involved in potentially dangerous substance use. And at the time, I was pretty emphatic about the fact that priority one is their life, preserving and protecting their life and their safety and their health. And a distant priority number two, in my view, was their privacy. And I sort of emphasized that rather emphatically in my comments. And so the friend of mine that was also on the panel sent me an email later after that conference and after that panel discussion. And this, what you see here is an excerpt from that email. And I think this is worth sharing. And he says here, today I spoke to a mother who attended, talking about the panel discussion that we had. About a year ago, they became aware of some alcohol and pot use by their teenage son. Since, she said, the mother said, they have been concerned, but they had no evidence of ongoing problems. As a result of attending the panel and particularly hearing me go off in the way I did about, health and life and safety being far more important than privacy, she and her husband decided to search the backpack of their son. They found evidence of ongoing and more serious drug use. They spoke to him, he admitted to it, and he's going to get treatment. And I saved this, and I asked my friend if I could make this into a slide and share this when I talk about this topic. And my friend kind of reluctantly agreed to let me do it. I still am not sure my friend is all that happy that I do this, but agreed to let me do it. And the reason is because this illustrates a key concept that you want to share with the parents of adolescents with whom you work. And that is, you need to have a high index of suspicion when it comes to your teens and potential involvement in substance use, and a low threshold for action. And that seems to be what was observed here. They didn't have evidence. What I thought was so interesting about this, those parents had no evidence of ongoing problems, but they just didn't feel right because they were aware of some alcohol and some marijuana use by their son. And so they just decided, well, let's just search his backpack. Let's just make sure. And because they had listened to me, they put aside, sort of stepping back because of being so worried about protecting his privacy. And then come to find out he's involved in ongoing drug use and more serious drug use. And then when they find that out, they don't fool around. They take action, and that kid's getting treatment. High index of suspicion, low threshold for action. It's really important. By all means, make sure that you teach parents that this is the way they need to approach young people that they think may be involved in substance use. Because especially now with an opioid epidemic that's going on, and with an epidemic of drugs that are not even opioids in name, that are being laced or contaminated with opioids, and particularly fentanyl, you can't really think that substance use that your young person is involved in is quote unquote low risk. You can't assume that what they're doing isn't potentially dangerous to them, even though they're quote unquote only smoking a little pot. And so I just feel like that's something that we need to teach parents. We in medicine, we're always taught this. We in medical school at Howard University, you heard that I went there for medical school. Our professors always told us, you can't make the diagnosis that you don't think about. You got to have a high index of suspicion to make a diagnosis. And that's true. But I couple with that the whole notion of a low threshold for action. Parents need to take action and not wait until they think things are quote unquote more serious, because sometimes that ends up being too late. All right, so here's some warning signs of teen drug use that it's worth teaching people about and sharing with people. Physical warning signs like fatigue and repeated health complaints. Obviously, the red and glazed eyes of someone who's actively intoxicated with cannabis or certain other substances. The lasting cough of someone who's already smoking cigarettes to some significant degree, or cannabis for that matter. There are emotional issues like personality change, sudden mood changes, irritability, irresponsible behavior. Many parents will say to me, and I've had them say to me over the years, that the number one change that they noticed most in their youngster was the argumentativeness, starting arguments. And of course, this is a time of adolescence when adolescents are supposed to be, excuse me, questioning authority and using their ability to engage in more abstract thinking rather than just the concrete thinking of latency age. But it's different. There's more arguing, there's breaking rules, there's withdrawing from the family to a degree that is significant. That's what's described here. And then in school, decreased interest in school, negative attitude, drop in performance, absences, truancy, discipline problems. And then, of course, with the friends, one of the common things we see as a warning sign is all of a sudden the kids who are engaged in the prep activities, the sports and cheerleading and the other, sort of what are considered to be pro-social extracurricular activities in school, those kids aren't the cool kids anymore. The kids that are cool are the ones who just sort of hang out and don't really do much in school activities. And maybe they, wear black nail polish, or they dress in all black or black makeup, or dye their hair black, or wear clothing with satanic symbols on them, or other things that basically express a real contempt for anything that people generally accept as more social and generally accepted societal values. Those are the kids that all of a sudden are cool. Those are the ones that the youngster wants to hang out with and have something to do with. And so those are some of the warning signs that you will see. Now, having said that, that doesn't mean that you need to see all of these or even most of these before you suspect that a young person has a problem with substances. And I will tell you, I have personally taken care of, just as the most glaring example that I always remember, I have personally taken care of a 15-year-old girl who met all full criteria for a cocaine use disorder, cocaine addiction, and a pretty severe one too. And this youngster was at the top of her class in school. All right, so it doesn't necessarily mean because one or more of these warning signs are absent, or in fact, the youngster seems to be displaying the opposite of that. Kid at the top of her class, no drop in grades, she was brilliant. But that doesn't necessarily mean that no problem exists. So that's why you got to have that high index of suspicion, a low threshold of action in terms of getting them evaluated if you have any concern, because not all of these warning signs are going to be evident. In some cases, very few of them are evident, and you're just gonna have to go with what tells you, what jumps out at you that this could be a problem and it's worth checking it out. So how does drug use start? Well, we've got experimentation, we've got periodic use, we've got regular use, we've got frequent or constant use, and then we've got addictive or compulsive use. And as you see in this pyramid, the largest number of folks will be involved in experimentation. A smaller number will go on to periodic use, and even smaller subset will go into regular use, and an even smaller subset into frequent or constant use. And of course, the smallest subset will engage in addictive or compulsive use. But here's what you need to pay attention to, is that death can occur anywhere along the spectrum of drug use. So even the kid who's only been experimenting a little bit with substances could end up with a death. And that's been, again, during the recent years of the so-called opioid epidemic, we've seen that more than ever with people who didn't even think they were taking an opioid. They feel like they were taking a little bit of Xanax, or they were just smoking a little weed, and come to find out it was laced with fentanyl, and they ended up dying of an overdose. So experimentation can cause death, anything along the spectrum. So that means parents and caretakers need to be concerned about any substance use from an adolescent. At least ask questions, at least check it out. And again, have a high index of suspicion and a low threshold for action. This young man, many people who are older among you, and I say older, I mean, you were around, you were at or near adulthood or beyond in the early 1980s, early to mid 1980s, then you know who this guy is. There's a whole ESPN 30 for 30 episode about him. And if you haven't seen it, I strongly recommend it. It's entitled Without Bias. This young man is Len Bias. And this is the most glaring example from a sport that I love, obviously basketball, of someone who experimented for the first time with crack cocaine. Why? Because he got selected number 2 in the draft by the Boston Celtics in 1986, number 2 overall pick in the NBA draft. And so he was happy, he celebrated. He was as you can see, at the University of Maryland. You can also see from these pictures, he was a heck of a player. What you can't see from the third panel on this slide is the guy who he's rubbed up against, he's playing against, and that guy's playing him pretty tight. This picture, it's cut off here, but I will share with you that this picture, this other guy in that picture who's trying to play defense against him is Michael Jordan. And at that time, Len Bias was considered to be a better prospect for the NBA than Michael Jordan. That's the kind of talent this guy had. So he's got, accordingly, was chosen number 2 in the draft by the Boston Celtics. He decided to celebrate by trying crack cocaine for the very first time. And those of you who are familiar with the situation know what happened. He died. He had a fatal cardiac arrhythmia and he died. Never got to play a day in the NBA. And so that's one of the most famous, to this day, examples of experimentation, not developing an addiction, didn't have an addiction. So it was pretty irrelevant whether he had a family history of addiction disorder, right? It's really irrelevant whether he had all those other warning signs of addiction or whatever. This guy experimented one time and he was gone. Gateway drugs, this is a term that very few people use anymore, except people who are, in their 50s and up very often, talking about alcohol, tobacco, and marijuana as gateway drugs. And yet a lot of people have this sense that if you start out as a young person with these substances, you are at increased risk for ongoing issues with substance use disorder. And in fact, that's right. And I've already shared with you the data that suggests that with alcohol, you have a 4-time greater risk of ongoing alcohol use disorder if you start at age 15. But what I also tried to point out a little bit earlier is that a lot of kids just start with what's hot. So whatever their friends are doing, that's what they're likely to do. And these are just some examples of that. A youngster in Boston who started with Vicodin as the first drug that he ever tried, because that's what his friends in high school were using. OxyContin in Florida. I made mention of a young person that I've taken care of before, actually a Vestavia High School student who was into cocaine because she had started with cocaine in middle school because that's what her friends were using at the time. And then of course, methamphetamine in certain places as well for kids, maybe the first drug that they ever try. It is true, though, that the drugs that adolescents use differ from the drugs that adults use. And this is a slide that tries to demonstrate that. This is the age ranges. Blue is 12 to 17. Orange is 18 to 25. Green is 26 and up. And you see with alcohol, the older folks tend to use that more. Marijuana, the younger folks tend to use that a lot more. And interesting how that drops off as you get to be over 26. The prescription drugs, the highest group is the 18 to 25 age range. And then with cocaine, heroin, hallucinogens, inhalants, those drop off significantly for the youngest group. But again, the 18 to 25 group are the highest of those. And then you see other groups as well. And those drugs, thankfully, are used much less often than these others anyway. So there is a difference, and that's been studied. Here's a chart of some of the evidence-based screening tools that I promised that I would share with you for adolescents and adults. And the one that I'm going to highlight here, since we're focused really on adolescents, is the CRAFT. The adolescent, the CRAFT is the instrument for adolescents, screens for alcohol and for drugs, and it is self-administered by adolescents, so it's easy to use. Adolescents can self-administer, or also clinicians can administer it. There's also the drug abuse screening test adolescent version, which is, again, can be self-administered or clinician administered, and specifically looking at drugs and for adolescents. So those are some screening tools, and you can see these other screening tools that also can be useful. But the CRAFT in particular, which I actually have in a couple of different places here, and the drug abuse screening test, adolescent version, are the ones that I can suggest to you for adolescents. Language matters. I am going to be speaking on this in some greater detail coming up soon, but I just felt like it's worth touching on this. We really have to, and for the reasons of decreasing the stigma of addiction and the stigma associated with addiction treatment, and for the purpose of helping people to recognize that this is a medical condition and it needs to be treated with the same respect and professionalism that we would approach any other medical condition, then we've got to change the language, because we're not necessarily just involved in a peer support model. We're actually medical professionals dealing with a medical condition, and so we need to use the language that respects people in that same way. So the term abuse is a pejorative term. We talk about non-medical use or just use. Dependence is ambiguous. We really prefer the term addiction. Physical dependence really is referring to tolerance and withdrawal, and we need to be clear about that. We no longer speak in terms of so-called dirty urines, or that someone dropped dirty or failed a drug test. No, they had a positive urine tox screen, or they tested positive on a test. By the same token, we don't talk about clean urines. We talk about a negative urine tox screen or a negative test result. Clean and sober, we really need to start thinking in terms of someone being in stable recovery or in remission from the illness of addiction. And we need to use first-person language. So we talk about people with pain. We talk about people with addiction. I've never taken care of an addict in my life, but I've spent my whole life taking care of people with addiction illness. And that we need to make sure we draw that distinction. It's about respecting the people that we take care of and respecting the work that we do in taking care of those people. Treatment, behavioral approaches. Motivational enhancement therapy is very often going to be where you start with adolescents, because you more often than not are dealing with someone who is in the first phase of readiness for change. In other words, they are in the not ready to change stage, the pre-contemplative stage of readiness for change. They don't think there's any problem, they don't have a problem, and so you really have to engage where they are and not engage in a judgmental approach, and help them do the thinking, do the inventory, so that they come to recognize whether or not what they're doing is in their best interest. Cognitive behavioral therapy is an extremely important behavioral approach. It's the treatment of choice for adolescent anxiety disorders and adolescent mood disorders, frankly. And then there's dialectical behavioral therapy, which has its place. The pharmacotherapies, for the most part, until fairly recently, the FDA-approved pharmacotherapies have been limited and still are, but they've been used for treatment of the co-occurring general psychiatric illnesses, for ADHD, for major depressive disorders. The treatments of choice are the selective serotonin reuptake inhibitors. For bipolar disorders, generally speaking, it's the second-generation antipsychotic medications that have come to be used as first-line medications for adolescents with bipolar disorder. And to be honest, many adolescents with bipolar disorder will end up on more than one medication, often a second-generation antipsychotic used as a mood stabilizer, along with an antidepressant at some point to address the depressive phase of bipolar disorder. There are also anti-seizure medications like Lamictal, lamotrigine, that will be used for bipolar disorders, and that are particularly good to address the depressive phase of bipolar disorder. And so those are important agents to remember. For anxiety disorders, like I said before, the treatment of choice is cognitive behavioral therapy, but the selective serotonin reuptake inhibitors tend to be useful agents for anxiety disorders, as well as some of the the serotonin and norepinephrine uptake inhibitors can be useful for anxiety disorders. What we want to avoid, particularly for adolescents with substance use disorder or those who are at risk for substance use disorder, we want to avoid the use of benzodiazepines in those youngsters, if at all possible. Even for panic disorder, even for what we hope to be short-term treatment of anxiety disorder, the benzodiazepines put those youngsters at significant risk for developing an addiction to sedative hypnotics. For the psychotic disorders, obviously the antipsychotic, second generation antipsychotic medicines are still the treatment of choice, and there are a number of treatments available for that. And then for substance use disorder, I'm going to come back to that because this exclamation point here is here for a reason, just as the question mark was there for a reason in my opening agenda. And then, of course, you must assess and manage the suicidal patient. And that's incredibly important. That is literally a lecture unto itself. But I just wanted to make sure that I mentioned that here, and I'll mention it again in a few minutes because it's that important. All right, so what, if anything, constitutes effective treatment? And this is where we get into the National Institutes on Drug Abuse's Principles of Drug Addiction Treatment. This is a manual that has been developed supposedly over 4 decades, but really now it's up to 5 decades of scientific research that has yielded these 13 fundamental principles that characterize effective treatment for people with drug addictions. And now we also have a NIDA's principle of addictions treatment for adolescents, the adolescent substance use disorder, NIDA's principles, also 13 fundamental principles, also based on literally decades of research into what works. And so when we talk about the fact that only 1 in 5 people who have a substance use disorder these days actually gets any kind of treatment, we need to recognize that at least half of those who are getting treatment, half of that 20%, are getting treatment that is not evidence-based. And it's important to recognize what the real evidence-based treatment is. So here's NIDA's principles, because I think it illustrates that well. And then I'm going to shut up because I see Dr. Robertson, who's turned her camera on to tell me that it's about time for me to shut up. So I'm going to go through this quickly, and then I promise I'm going to shut up. So number 1, adolescent substance use needs to be identified and addressed as soon as possible. That goes to that, high index of suspicion, low threshold for action. And adolescents can benefit from a drug abuse intervention, even if they're not addicted. And I tried to show you that even when they're at the stage of experimentation, they can be in danger. Routine annual medical visits are a great opportunity to ask adolescents about substance use, but to do so in a non-judgmental way. Legal interventions and sanctions or family pressure may play an important role. Substance use disorder treatment needs to be tailored to the unique needs of the adolescent. Treatment should address the needs of the whole person, not just focusing on their drug use. Behavioral therapies are effective, but also family and community are important aspects of treatment. Number 9, effectively treating the youngsters means that you also have to address the co-occurring general mental health illness. And that's why this topic was on both. Sensitive issues such as violence, child abuse, risk of suicide, got to identify and address those. It's important to monitor ongoing drug use during treatment. Staying in treatment for an adequate period of time and continuity of care afterwards is extremely important. And then, of course, testing for sexually transmitted diseases like HIV, as well as hepatitis B and C, are important parts of treatment. And then the last thing I'm going to say is that we have to know that pharmacotherapy, when it comes to opioid use disorder, medication for addiction treatment, MAT, not medication assisted treatment. It's now properly known as medication for addiction treatment. That is the clear standard of care for adults, and it also is recommended for adolescents and young adults. And unfortunately, it is underutilized. I'm going to stop there. I know that I'm out of time. Remember, if this is a chronic disease and it's treatable and controllable but not curable, that means you never give up. because even if a person's had multiple relapses, you got to get them back into treatment. So you don't give up. You don't ever give up. And I'm going to stop there. Thanks, Dr. Robertson, for letting me know when it's time for me to shut up.
Well, yeah, I hated to do that because it was such great information, but I do have two questions that I want to try to get to really quickly. So the first question is, how long does it take for rehab to get off these medications, because so many insurances have a ceiling?
Oh, so many insurances what? I'm sorry?
Have a ceiling, a cap.
Right. I will say this, as a member of ASAM and as a member of the APA, the American Psychiatric Association, and as a member of the American Academy of Child and Adolescent Psychiatry, we are actively fighting those ceilings because those ceilings don't make any sense. If you believe what I told you, that these are chronic conditions that have remissions and exacerbations, then there's no place for those ceilings. We can't have ceilings for the treatment of these illnesses. So that kind of parity is what we're actively fighting for. In the meantime, obviously when you taper someone from a medication, if you have to do so, you want to do so as carefully as possible, working very closely with the patient, and in the case of adolescents, with parents, to make sure that as you taper, you're not experiencing a recurrence of symptoms, because if you do, then it's your responsibility to go back up on the dose of medication to the effective dose, and then you've got to let the third-party payers just know that that's necessary. The care of the patient always comes first, but that's the way you do it: is carefully, slowly, as a team with the parent and the patient, and try to minimize adverse effects as you're tapering people off of medication.
All right, great. Another question: can you briefly explain the relationship between addiction and religion, religiosity? Sorry, I got tongue-tied. Can you explain that again, please?
Sure. There was a specific study that I was really citing that looked at, and I have to find that reference, and I'm sorry, it was quite a while back when I prepared that slide, but I can find that reference, that looked at adolescent girls and what they summed up as religiosity, the extent to which they attended regular church services, were involved in ministries in whatever church or worship center that they were involved in, and found that there was a correlation between delayed onset of drinking, abstinence from alcohol, and choosing to delay their beginnings of use of alcohol, and being less likely to drink excessive amounts of alcohol. All of that correlated with those youngsters who were more involved in religious services, and therefore, as they characterized it, having higher levels of religiosity. And in fact, there have been other studies that I've heard about, but I have to get specific references that look at that in other populations as well, males and different age groups and what have you. But that was being cited as one specific study.
Thank you. And I just have one more question. One more came in, so this will be the last one. What time frame would you consider treating ADHD with stimulant once patient achieves abstinence?
That's a tricky one. In my own career, I've been one who will avoid stimulants like the plague in youngsters with substance use disorder, and I will use other agents like atomoxetine or bupropion that have either FDA approval in the case of atomoxetine, or in the case of guanfacine, also FDA approval, or just a body of evidence that suggests that it can be effective, which is the case with bupropion, even though it doesn't have FDA approval. But I will use those agents and exhaust those possibilities before I will go with a stimulant. But I certainly would not recommend, before a youngster's been in stable abstinence and stable recovery for a year, before I would even try a stimulant. Remember, the priority is this: the substance use disorder could potentially kill them. So that's the most important disorder to treat and stabilize. ADHD, for the most part, isn't nearly as fatal as an improperly or inadequately treated substance use disorder. So that takes second priority. And if it means that you've got to wait a year without them getting that treatment so that you can make sure that the substance use disorder is stabilized, better to do that. So that is the way I would approach it if I absolutely have to do stimulants, but I really try to avoid stimulants like the plague in young people with substance use disorder.
Well, thank you very much. Like I told everybody, some great information. I knew I needed to hurry up at the beginning because he had some really good information. And want to thank you, Dr. Taylor, for this presentation and for the past one. It's been wonderful. Thank you all for joining us. Thank you, Dr. Taylor, for giving us this great information. And we will see everybody next time. Thank you. Bye.